Welcome everyone, and thank you for joining us for today's webinar titled Best Practices to Achieve Quality PV Loop Data. My name is Andy Henton from Inside Scientific, and I'll be your host for today's event. Today's session is actually the fourth installment in our PV Loops to Measure Cardiac Function webinar series, and we are happy to share that since beginning the program, 500 scientists from all over the world have registered. So for those online today, we offer a warm welcome, and thank you for being with us. Our session today is sponsored by Transonic and is really a collection of tips, tricks, and best practices that scientists can apply to all preclinical research applications of PV loop research. First, we will hear from Peter Plouf, Director of Research and Development for SciSense Products at Transonic, and following from Dr. Filip Konecny, Application Scientist and Surgical Trainer at Transonic. Together, they represent decades of experience relating to the science of PV loops and hemodynamic research, and will deliver specific instructions that can be applied at the benchtop relating to both surgical and equipment operation best practices.
Good morning, everybody, and I want to thank everyone for attending this meeting. As Andrew mentioned, my name is Peter Plouf, and I manage the R&D department at Transonic SciSense. I spent the last 10 years working with SciSense to obtain quality pressure volume data, originally using the traditional Bond's equation methods, now for the last 5 years using the improved admittance technology. I'd like to use this opportunity to pass along some of what I've learned from working with scientists over this time frame. There we go. Went to sleep. So the main thing is to be confident in the data you collect, but do it when you're collecting it. The time to invest in data quality is before you perform the experiment. So due diligence in selecting the proper equipment to use with your PV system. Know how to use it will save time and animals when you're performing data analysis later on. So the purpose of this first section of the presentation is to present a series of best practices that will evoke confidence in your PV loop data while you're collecting it. So when followed, the tips and tricks and sanity checks will prevent researchers from collecting inaccurate data. So PV acquisition is not a standalone technology. The researcher will be assembling a system or systems of equipment for data collection and surgical needs. It's important that due deliberation be put into the selection of the system components and their use. So at the heart of any PV studies, the researcher will have the PV catheters and control box, the data acquisition and data analysis system. The components come with comprehensive manuals and instructions on use and care. Please read the manuals and call us for help if there's any doubt about how to use any of these components. Transonic SciSense understands that there can be questions when setting up for PV studies, and we're here to help you. Transonic SciSense is familiar with most data acquisition systems, and we can help you with their integration with our technology. For most injectable, the use of ventilators, for most injectable anesthetics, the use of a ventilator is going to improve stability of the hemodynamic variables. Ventilators will help control the artifacts caused by gasping during study in many cases. When performing mouse studies, it is best to use a ventilator that is optimized for the small size of the mouse. One size does not always fit all. Similarly with vaporizers and anesthesia kits. The thing to keep in mind is that consistent delivery and control of anesthesia can be just as important as the type of anesthesia that is being used. Brings me to surgical tools. Of course, they're essential for the actual surgery and blunt dissection. But the point I want to make here is that you have a great opportunity to avoid damaging the catheter if you handle it properly with forceps. Now by properly, I mean use forceps that are especially configured for handling microcatheters. or if you don't have those, use forceps that have had the ends covered with a soft PE tubing so as to avoid crushing the catheter shaft. Equally important with these tools is to develop a feel for how the forceps grip the catheter. Too much grip is going to leave marks on the catheter that over time are going to shorten its life. It's important to develop a soft touch that does not crush the catheter tube while using it. And we actually provide you with a practice catheter when you buy one of our catheters that you're welcome to practice with, find out where its limits are, and better understand this without inflicting any damage on a new catheter if you're not familiar with how to use them. Microscopes. For rodent surgeries, I consider a surgical microscope to be an essential tool. The microscope will help the surgeon see the catheter as it is gripped by the forceps, and will help develop the soft touch that I had mentioned previously. Now, another good thing about the microscope is that it will avoid the necessity to use the end of the catheter as a blunt probe while the surgeon searches for the entrance of the vessel. Once again, helps prevent any damage to the catheter through blunt force on the end of it or kinking of the catheter as you're pushing against a non-aligned vessel. Before starting, data collection relies on a properly set up system which will consist of the ADV 500 and an A to D device and a data collection software program. Assuming your system's assembled to your computer and you're familiar with your acquisition system, it's important to make sure that your system is working, calibrated, and ready to go. So the ADV system displays high and low calibration values that are used to calibrate the acquisition system. A quick method to check that any PV system is set up for proper use is to use the calibration outputs on the PV box and compare against your computer screen display. So the image is showing the ADV 500 screens outputting values for pressure, volume, phase angle, and magnitude in both a high and low calibration value. So regardless of what data collection system you have, the process will be the same. You look at your screen and ensure that the low and high values, in this case millimeters of mercury, microliters, phase angle, and magnitude, agree with what was output on the screen. Now we're showing a picture on the bottom that are showing the high values, and you can see with each of these popular systems that they're in agreement with the high values. You can be confident that your system is calibrated from the box to the screen and you're ready to go to work. This sanity check is especially useful in labs where people share a PV system. There may be various setups for mice and rats, or somebody may have altered the system. The message is you don't want to go to work and collect data with a saved file that is no longer correct. On the subject of catheter selection, a PV catheter has 4 electrodes, 2 on the distal end and 2 on the proximal end. It's vital that all 4 of these be inside the ventricle. Single segment catheters are available with segment lengths as small as 3.5 millimeters for small mice and all the way up to 100 millimeters for large animals. A good tip here is if you're in doubt, it's a little safer to err on the side of too short of a catheter rather than one where the proximal electrodes will be outside of the ventricle. The other option with catheter selection are VSL catheters, variable segment length catheters offering 4 different sensing length options per catheter are available to accommodate studies where ventricle sizes vary. Now this may be because you're not sure what size the ventricle is. It may change from animal to animal, or perhaps you are visiting the animal after a time frame where it may have aged and grown. These variable segment length catheters are available in sizes from 1.9 for rats up to 7 French size for larger animals. Transcending SciSense does have a simple catheter selection matrix that will help researchers with the choice of catheters. As Andrew indicated, this information will be available after the presentation, so there's no need to scribble it down. The critical takeaway from this slide that the researcher needs to put some due diligence into is the recommended long axis should match an expected ventricle length, and do be aware of the maximum volume expected during the study. Once again, if in doubt, give us a call. We can help you. They often misunderstood or not performed part of studies is the hydrating and balancing of the pressure sensor prior to using it. For best results and minimal drift during the experiment, it's a good idea to start hydration of a catheter 20 minutes prior, at least 20 minutes, I would say, prior to the experiment, and it should be plugged into the system. I like the use displayed here where you put the catheter inside of a syringe. It offers some protection to the catheter, keeps it hydrated, and if you look carefully, it's also at the surface, or can be held at the surface. After the 20 minutes soak, but before the insertion, the control boxes offer balance controls to zero the reference pressure. As indicated, it's a good idea to have the catheter just under the surface of the water. You do not want to balance the catheter at the bottom of a water column. You'll introduce an offset that will then show up during your experiments as a negative value. Be aware that once the catheter is inserted into the animal, you are no longer able to balance it and you'll lose the reference of the atmospheric pressure. So due diligence and calibration is what's going to provide you with accurate data. While the pressure signal in PV studies is a calibrated signal as an output, the volume signal, whether it be a bonds or an admittance signal, is going to be calculated value that will require the input of calibration parameters from the research. So in order to calibrate calibrate your admittance signal, you require 3 calibration factors: a stroke volume calibration factor, a blood resistivity calibration factor, and a muscle electrical properties factor. The stroke volume calibration factor maps the measured blood magnitude to a known cardiac stroke volume. Now, the most common ways to obtain this information are illustrated on this slide. Echo technology is optimized for rodents, has been gaining popularity in the last several years, and is now available in many research centers. For either bond or admittance users, for many years, transonic transit time flow probes, the second from the left, have been a gold standard for obtaining cardiac output and stroke volume for volume calibration. For larger animals, the Swan-Ganz catheter has been used for measuring cardiac output and deriving stroke volume, which can then be used for calibrating admittance systems. Finally, when necessary, it's often possible to find comparable studies in the literature that will provide reasonable estimates of cardiac output and stroke volume for a given experimental protocol. The blood resistivity is an important calibration factor that needs to be considered. It's a property of the blood being measured and is not a variable during the experiment. The ADV 500 provides default values that represent healthy, non-modified mammalian blood at 37 degrees C. So if your experiment involves changing blood properties, for example, during a hemorrhagic shock study, it would be a good idea to actually use the supplied probe with the probe supplied with the ADV 500, and following the illustration, take an actual measurement of the blood as it pertains to your protocol. Once again, you're ensuring the accuracy of your data by performing these due diligence steps. Moving on to archetype, which are the muscle electrical properties used by the admittance system. The ADV uses the term muscle properties to describe the ability of the myocardium to conduct a constant AC current signal. Now, it's important to acknowledge this calibration parameter, since it's going to impact how much tissue contribution is removed from your measured admittance signal. The ADV offers 3 default options based on heart type. There's a setting for healthy, there's a setting for infarcted, and there's a setting for hypertrophied, which covers the majority of situations that we run into. Now there is a 4th option, which is to select a custom, and you can use the supplied probe, which is the same one you saw on the previous slide, measuring the blood conductivity. And you can obtain a value by placing the probe on the LV surface of a beating heart. So once set up and calibrated, the ADV 500 offers easy access to all the calibration parameters. You can see in this case that they're observable through the user interface. At a glance, you can tell what settings you are running your experiment with. I highly recommend that you write this information down in your experimental notes for future reference, or in case you're going back and trying to sort out, post-process your data. The ADV 500 also offers the user easy access at any time to the calibration parameters or to the segment selections for the catheter by a single button push from the main panel. In the case of the calibration parameters, you can see the blue buttons, and then if you were selecting different catheter segments, they would be the purple buttons. So at this point, if you've followed along, you should be confident in your surgical, data collection, and PV system. You're ready to move on to the surgical side of the experiments, which will be presented in a minute by Dr. Konecny.
Thank you for having me as a presenter today. Hello, good morning, everybody. My name is Filip Konecny, and I work at the Transonic Science Office as the application scientist and the surgical trainer. Here, for about 20 to 25 minutes, I will try to go over about 20 slides that I'll touch on the surgical consideration and the best practices for successful PV data collection. Here in the overview, for the quick overview here, I would like to be discussing the best practice of the surgical and a surgical consideration for PV work, and also touch on optimizing PV volume signal, namely on importance of the catheter placement, performing baseline anesthesia and baseline scan, validating your baseline data, and then 3 steps to good collection of the PV data. Our first slide here talks about anesthesia, analgesia, and ventilation. It is important in PV. Please do, before you start your PV, weight each subject and calculate proper anesthetic dose. Please also adhere to suggested delivery and administration guidelines for selecting anesthesia and anesthetics. I have referred to table in the ROD and PV workbook. We were fortunate to write, as a Transonic Science, a workbook, and it's a great resource for many researchers, I found, and it is posted on the Transonic website for download as a PDF. And when we move next, it is also good to learn about the anesthetics and the effects on hemodynamics before you start your PV research. In this section, do not use, please, expired pharmaceutical grade injectables. Do not use expired anesthesia and sedative antagonists. And also do not use, please, expired vaporizer or non-compatible vaporizers. So moving along, what to do? Please administer analgesia to control pain in PV work. Analgesia helps to reach a surgical plane of anesthesia faster. Also, please, I have learned over the years that PV require working with a friend or somebody can help you with the procedure. He or she can actually pre-anesthetize the animal while you're concentrating on the position of the catheter in LV. Also, maybe the other person or another set of eyes can help you with the maintenance of your isoflurane setting, for example. And I found that 0.5 to 1% of isoflurane setting, it's great for your PV exam. And this person will tell you, well, you are still on 3 instead of being on 0.5 to 1. And also helps you to monitor vital signs of the animals while you are fully engaged into catheterization. See that tip here, it's a select anesthesia that can be readily reversed and have a predictable effect on the heart. That's key in the PV research. Further, monitoring physiology. Please do. Monitoring physiology science is at most important in PV because you're looking for overall hemodynamics. So the best practice is at least to monitor body temperature, some sort of respiration rate, and ECG. There's a complete solution on the market which provides like the system on the right side of that slide. It's called Mouse Monitor S. This monitor displays core temperature, heart rate, for example, breath rate, blood oxygenation, ECG, respiration, and plethysmography waveforms. Maybe it's too much, maybe it's not, but this is another advantages in PV research, to have the vital signs monitoring while you still continuously save data throughout the experiment, and or maybe integrate the PV signals into the one acquisition file to have everything included in one file to just maybe refer later on what happened here, what happened there. So one acquisition file works for me. Here I put some monitoring physiology, heart rate, blood temperature, respiration rate for mouse and rat. It's fully downloadable from the website. Andrew, just give me a go-ahead to say that. Yes, in this slide, it is fully downloadable. You can download it later on. You don't have to rewrite anything. So moving along here. So one additional thought about the heating. If you are not going to use, some labs don't use integrated solutions like the monitor I showed you before. So there are other body temperature maintenance options. Heating pads. Please refer from the equipment which is not designed for surgery. I've seen it in many labs going around the country. Water-based equipment is much better for the PV. It injects less noise into the PV system, and also is proven to be safer when it comes to the pad-associated skin burns and maybe dehydration of your animal while doing the PV work. Moving to the next slide, there's a consideration, I call this slide hemorrhage. It is important to protect the circulation blood volume during your PV research. This leads to a protection of blood pressure and overall hemodynamics. So for example, loss of 10% is very fast in mouse, and it's tolerable for PV. But loss, for example, 20 to 25% will lead to shock, and then final data will not be physiological. So the good PV vascular prep should somehow find a way to minimize the blood loss. So in this table I showed you mouse 20 gram. It has a probably amount of volume, circulating volume 1.5 mil. And the blood loss 0.15 mil is very fast to lose that amount of blood. So please make sure when you're catheterizing, don't lose that amount of blood. Otherwise, you are running into non-physiological data. So in the next slide, I put the blood replenishment, how you maintain the blood volume in order to have PV data. As a good practice, I would say it's a replenishment before you start your experiment. So before you insert the catheter, you understand that the right carotid artery or open chest has to be open and the heart has to be stabbed through the apex. So you will lose the blood. You will lose eventually blood out of this during this procedure. The best practice is to, for example, replenish the lost blood before you start the PV, or you doing during the procedure. You write your SOP for injection plan and do it during the procedure. But I suggest do it before the procedure begins. So going to the surgical documentation, it's about surgical documentation. We have created a PV document sheet which can be downloaded from the website after this session, and it's in the Excel sheet version. In this document, we basically says, please write the document surgical methodology and operation details. Work through the cohorts if possible. If different animal groups have, for example, different volume calibration factors, SV correction factor, or require PV catheter with different electrode spacing, just write it down in this document. Or also, very important, what I found through the years, utilize marks in the software files. So variety of software Peter showed you, like for example, iWorks or ADI or IOX. Please make notes within the file for your own safety, because for example, you can write in the file blood resistivity 1.4, heart type normal, stroke volume 21.3 microliters, and etc. Or maybe you can write segment what you used, or maybe you can, when you perform the occlusion, you can write occlusion 1, occlusion 2, occlusion 3, so you mark everything in your file for your later reference. So here are the three steps to have a good PV data. Peter touched on the step 1. Turn on the system and start catheter hydration. Step 2, maybe enter values for admittance, cal factors, stroke volume, blood resistivity, heart type. Then you balance your pressure sensor. Step 2, place the catheter into the ventricle. Position the catheter into ventricle and obtain pressure versus magnitude loops. Also look at the phase signals while you're doing this. Once the optimal signals are achieved, press enter and acquire what we call a baseline scan. Accept and report scan numbers or rescan if needed. We will also talk about switch to pressure versus volume loop after you obtain positioning and pressure versus magnitude loop. And then continue with the protocol while you're injecting, for example, drug candidates, or you occluding, doing IVC occlusions or other occlusions, IVC with SVCs, and later on use the software analysis features to study hemodynamic results. So moving towards the transition. In this slide, I would briefly touch upon the transition guidance, which is enabled by your catheter when catheterized through the RCA. Please note the drop of the pressure at the end diastole when entering into LV chamber through the RCA right carotid artery. You see the orange arrow pointing where that drop happens. So that's possibility of guidance by pressure. So here we have a slide about understanding magnitude. When catheter is inserted in LV, as it is in this mouse example, after being guided by pressure, aortic to LVP transition, other signals comes now into play. Please note that the last channel is called magnitude or raw conductance. When catheter is inside the ventricle, please try to maneuver catheter such you obtain ranges between 900 to 2000 for mouse, example here, or with 200 to 500 amplitude. Please also try to have a sinusoidal pattern of the waves as pictured here on the slide. So when it comes to the next signal you will observe when you put the catheter into the ventricle, it's called signal phase. Phase is the third channel, and it's live during the catheter positioning, and it's guiding the catheter position within the chamber. Something like I would always call it when I'm out in the field, like a sonar in the cavity. And this will basically help you again with your positioning of catheter inside the cavity. This is for mouse. The values are for mouse. You can fully download it from the website. Here, I put typical values in the healthy subject. For example, here we have a rat. Phase range is 2 to 6, phase amplitude 2 degrees, and magnitude range 1400 to 2600 microsiemens with the magnitude amplitude 600 to 1000. So this again, I won't go deeper in this table. It's fully downloadable out of the website. Here, sign of the good baseline scan. So we're going through the steps as I showed you in this slide. And here we see the signs of the good baseline scan. After all signals, pressure, phase, and magnitude are controlled and having similar pattern as shown in the previous couple slides. Baseline scan should be performed. This is very, very, very important. When scanning for baseline, push enter button on the ADV 500 unit and observe short break, and I'm putting cursor where that short break occurs. And this will, you will observe it on your computer screen using different types of software, but you will observe that short break. And the result should be stable, accurate volume, and if not, try to repeat, adjust the catheter, repeat again, and redo the baseline scan. Okay. On the next slide, this is critical. On the next 3 slides, I will demonstrate what seems to be a reasonable pressure raw conductance loop. Here we have pressure versus raw magnitude. And we see that loop looks good, but could be inaccurate. And here we can basically show you how the admittance system identifies the need to adjust the catheter positioning in real time during the data collection. This is real time during data collection. You see, well, my loop looks good, right? But this is reasonable loop, it looks good, and however, the catheter still needs to be repositioned. And people ask me, or researchers ask me, why you need to reposition? You have a good loop there. And I say, let me show you how the loop looks like in a pressure versus volume with the same data from this slide. This is how it looks like. Okay? So on this slide, we see that the pressure volume from the same previous slide, but we see the same data, and now we're viewing pressure versus volume. The volume is not calculating correctly, and this is because the catheter is not in the center of the ventricle. And this is because the phase angle, if you notice on the slide before, is between 8 to 10. But what we said about the mouse, we should be around between 2 to 8. Now we see that if this third signal, the degree of the phase, is not within 2 to 8, that's how the final loop will look like if you plot pressure versus volume. If you later on correct, this is how it will look like. The catheter position was adjusted and was followed by baseline scan. Volume is now accurate, and then user can move freely forward to their protocol. Either they inject drug or they going into IVC occlusions. Okay, so here I'd like to recap what we've seen so far. So there's 3 steps to have a good PV data. First thing is turn on the system, start catheter hydration. Enter values for admittance cal factors, stroke volume, blood resistivity, heart type. Balance your pressure sensor. Place the catheter into ventricle. We've seen it together. Position catheter in the center of ventricle, which will help you. And I give you the hints how to position it. Pressure, magnitude, loop is the first. And then look at the phase. Phase is important signal, and it's alive. So you can, this phase signal can help you live to trace the position of the catheter within the ventricle. Once optimal setting is achieved, press, and you have to still do the acquisition and still perform the baseline scan. Then you accept or rescan if needed. And then you switch to pressure versus volume loops, and then continue with protocols with injection, dobutamine, beta blockers, etc. Or you do occlusions, etc. and write it down in your software. Occlusion number 1, occlusion 2, bad occlusion, very good occlusion. And use software analysis later on to study the hemodynamic results. Okay, so here we put some resources on the website, and they said it will be freely available. It will be the resource of the PV workbook and the PV loop documentation sheets, which will help you with the research. And this is probably everything from me. Thanks everybody for your time. And now we move to the Q&A session. Thanks again.
Perfect. Thanks, Philip. That was great. And yes, we've had you know, a ton of questions come through during our session so far. So I'm going to get started with the first. And actually, I'd like Philip to get your input on this. But then at the same time, I'd like our audience to, through the communication window, chat or sorry, to send in through the question panel what they use. So the question is, actually this came from Carla Weinheimer. Carla, if you're still out there, thanks for being online. What anesthesia is most widely used by PIs doing PV measurements? So I thought this one would be a nice one just to say, you know, to all those in the virtual audience today, that we've got over 100 people online. You just cast your vote, type it right in through the communications window. We'll be able to collect these and you know, basically bring them all together as part of our Q&A report. But then Philip, you know, you can obviously share your own,
yes.
so to speak, now live with the audience.
Yes, I have that anesthesia question all the time. The anesthesia question, what I've seen so far in the field is use of isoflurane. The question is why. So I dug into this because the minimal alveolar concentration of isoflurane, what the minimal alveolar concentration is, by definition, is the concentration of the vapor in the lungs that is needed to prevent movement in the 50% of subject in response to surgical pain stimulus. So that's what I'm thinking is isoflurane, if you look at the tables, which is widely available by Dr. Mapleson, I believe he published it in 2003. There's a table in this paper, I believe, where it cites minimal alveolar concentration. And if you look at the minimal alveolar concentration in the table, isoflurane is about 1.17%. So it's very convenient anesthesia, and also it's very fast. And if you look, I believe, in isoflurane publications, it basically says it doesn't interfere. At the beginning, it does interfere with, it depresses the blood pressure, but at the, if you set it up 0.5 to 1 and later on, it doesn't interfere as much as other anesthetics with the cardiac, with the heart, with the cardiac, with the hemodynamics. So isoflurane is preferable anesthesia in animal research, and I've seen it in many laboratories around the country. Yes.
Perfect. And actually, that's right on point. I'm watching our communications window just grow with votes from people here that are online, and for the most part, it is isoflurane that's being the major response coming in that I see. Obviously, people have stressed in some cases, oh, we're doing a dog study, and there's maybe some combination of injectables as well, or
Yes.
maybe they're using sevoflurane. We've seen a couple of those. But yeah, great to have everybody. Well, first of all, great answer, but also great to have everybody chiming in here and sharing what they're doing. So feel free to keep that up if you haven't shared what you do yet. Keep going. But moving on to another question. We've had a couple people, like you used the terms magnitude and phase frequently throughout the presentation. So we've had a couple people ask about these signals, and I guess kind of grouping their questions together, the best way to say is, can you explain in more detail what both actually magnitude and phase are? Like, what are we really looking at? What are they seeing with those signals? And then somewhat like, why are they important? And maybe stress the importance of the phase signal, because that was one particular question that came through.
I think I'll take that one, thanks.
Mm-hmm.
The magnitude is the AC current or electronics version of conductance. Conductance would be a DC signal, and since we're using AC theory and admittance technology, we switch to the proper term with it, which is admittance. For all practical purposes, conductance admittance can be used interchangeably for the purposes of PV loop observations. It's actually an indication of how much blood is in the ventricle at any one time. There's a semi-linear relationship between the measured admittance or conductance and the amount of blood. It's what the Bond's equations and our Wade's equation with our system uses to track and convert to volume. Phase angle is more fun, and I'll try to stick to the less technical answer. The full technical answer is available in our research package or on our website, and certainly available after the presentation. Simply, phase angle is an electrical term that's used to indicate that one sinusoidal signal is leading or lagging another one. So big deal, right? Doesn't tell you a whole lot if you're a researcher. But for our purposes, the phase angle is used as an indicator that some portion of the electric field is traveling through the myocardium. So in other words, it represents indirectly what is known as the parallel conductance part of the signal. So from observing the phase angle, we can tell that parallel conductance is actually happening and that it's varying throughout the cycle. Through the admittance algorithm, we then combine this with the muscle properties, and we can subtract the amount of volume that is estimated to be traveling through the myocardium rather than through the blood. From another practical consideration, Philip used the word sonar when he was talking about the phase angle. I look at it slightly different, but the reason that we include it in the displayed signals is that it provides the user with a relative indication of the catheter position within the ventricle. For example, the lowest possible mean phase angle value in a 2 to 3 degree span would indicate a good catheter position. Independent of what animal you're in, you're looking for the lowest mean phase angle you can get with, say, a 2 to 3 degree sinusoidal span. What that indicates is that you should be in the center of the ventricle, and you're watching as the myocardium approaches, which gives you a high phase angle, and departs, which lowers the phase angle. And that gives you some assurance that you're in a good position. His last few slides spoke to this, and an experienced researcher would know from doing this a few times on a mouse what's a representative phase angle, and he would strive to get that every time. Philip used sonar. I like to think of it as a stick to locate yourself in the middle of a dark room. Is more the image that I use.
It's a good analogy.
I find it very useful in that besides being the electrical trick for doing parallel volume subtraction.
Right.
I hope that cleared it up a little.
No, I think that's definitely a good overview, and it's great to know that, again, for those out there that are also interested in some of the more technical background to the derivation of phase and its integration into Way's equation, which you mentioned is, the term or the equation that is used to produce admittance volume data, versus Bond's equation, which would be that traditional, where all this PV loop science started. Bond's equation has been being used since the 80s, I believe. So very, very good. Another group of questions. So again, I'm reading through some here, and they really relate to ventilation. So maybe I can position this as, in all cases, should someone be using a ventilator, and what would the benefit be? So probably Philip,
Yes.
can I direct this to you?
Yeah. Well, certainly yes. Ventilation is important, and then why is the ventilation important? Because we know that the positive pressure ventilation, for example, improves blood oxygenation. It also helps lungs work more efficiently and allowing reduction of inspired oxygen concentration, and also limits CO2. And if for example, CO2 increases, you might get into respiratory acidosis, which leads to, I believe, in decrease of cardiac contractility. So what you're really aiming towards by ventilating animals is to get into more physiological space. So you trying to do ventilation because you measuring physiology. So your baseline should be more physiological without any respiratory acidosis in this example, for example. So yes, I would use ventilation to get clear physiology baselines. That's my short answer.
Okay, very good. And maybe in the same accord on ventilation, we've had some people chime in about having gasping issues. So maybe specific to the mouse model, I'm hoping that we're having some heads, or I'm assuming we're having some heads nod out in the virtual space there of those that are online saying, yeah, we have gasping challenges at times. Just maybe short, are there any tricks that people can consider here?
Gasping, yes. Hypoxia gasping might be observed maybe under severe hypoxia or complete anoxia. It's in various species I've seen so far, like mouse, for example. It's life protective, I would say, reflex. It's a minimal ventilation that has to be even during the loss of consciousness. It's a reduced oxygen supply to the brain, and which triggers, I believe, the sequence of respiratory responses, and then which you've probably seen tachypnea before complete starting gasping, and then it's gasping. So if you follow further, it's complete depression of the frequency of the breathing, and then it can lead to hypoxic coma. So how you prevent that? Well, from the mouse ventilation standpoint, I would what I would do, I would look for the ventilation guidelines. I try to put in the PV workbook. It's downloadable from our website, as I said previously. I put the tidal volumes and respiration rates for animals, and you can actually calculate it also yourself. So when you set in a volume ventilation, tidal volumes and respiration rates are very important, and it's downloadable from our website.
Mm-hmm.
For large animal researchers, I've seen using paralytic agents like a pancuronium, but you have to be sure, you have to also know that the pancuronium does not have sedative or analgesic effects, and also the side effect of pancuronium increases heart rate, I believe, and arterial pressure, cardiac output, and also salivation. So for the mouse, I would play with the ventilator.
Yeah, I was going to say it's great that you touched on pancuronium, because we had a question come in from Julie Harrell, and she mentions experimenting with this. So that's maybe something to consider, is that
Okay.
Experimentation is fine, but think about the consequences, especially when using drugs, and how this might influence hemodynamics.
Yeah.
On the same talk about ventilators, like certainly from a physiological point, you approached answering that question. I think one thing I would share just from my experience as well is that not all ventilators are the same, and there is some experimentation there. There's different models, and Pete, you touched on this, right? Like some are particularly good for mice,
Yes.
and some for rats, or some both. I mean, just very high level with the no reasoning. Have you guys seen particular ventilators that perform well in a mouse, like that just for the most part are really bankable?
In a PV space, I've seen the Hugo Sachs, the ventilator Peter showed on the image.
Yep.
One of the slide, the Hugo Sachs works for me. It's a volume ventilation and works like a charm. Okay.
Very good.
I believe that's a mouse.
It is mouse.
Yeah, so that would be for mouse. I'm just, there was a great question that came in earlier, and I want to find it. Give me a moment here. It basically talked about, again, relating to ventilators, but how this might influence baseline data and when you're doing occlusions. And I think what the person is hinting at is the value of basically doing a pause on the ventilator.
Yes.
So can you elaborate on why that is valuable, and how that, again, as a best practice, might influence the quality of your baseline data, and also when you do load-independent measurements by occlusion?
Again, I'll take probably this question. Or Peter. This influences, if you stop, usually what I do when I do my preps, I stop ventilation in the inspiration phase, if you can do so, in larger animals. In the small animals, it's sometimes difficult because the piston in the ventilator is very fast, but I'll try to do that also in the inspiration phase, and it's recommended also when you do PV research, trying to stop the ventilator in the inspiration phase, and then observe the channels live, especially pressure, and after that period of nice data, which are usually without any interference or any gasping, now you occlude. So this pre-occlusion data, which helps with the stabilization of also the catheter in the cavity. I've seen many times that after stopping the ventilation and inspiration phase, the catheter magically get into the middle of the ventricle, and you do occlusion, and you have a beautiful ramp of pressure and volume going together. So yes, it always helps. And again, going back, why we ventilating animals? Because we have better control over the prep.
That's a great answer. I think that exactly is what we were touching on. I found the question now. It came from Mark DeMulder, so thank you, Mark. Or it was more of a statement about switching ventilation off. It's a practice that he uses. So very good, guys. Well, we've come to the close of our session. There are tons of questions still coming in, and Transonic will definitely get to answering all of these in what we call a Q&A summary. So the slide deck, a summary of the responses to questions from this session, and then the full recording of today's webinar will be made available to everybody a few days from now. So look out for that. In addition, I want to take time to mention the next session in this series. It will be held on Tuesday, March 17th, and Dr. James Clark of King's College London will join us to present. It's a great segue on this. It's basically very specific surgical monitoring best practices, and how, again, we stress the word integrated surgical monitoring is used when combined with hemodynamic measurements, and the value of that, and how it can help you control animal outcomes and really improve your cardiovascular results. So this session is sponsored by Indus. So yeah, please join us. Everybody online is automatically registered. So we hope to have you there. Furthermore, you may have received announcements about a rodent microsurgery and hemodynamic measurements training program. The next sessions for this, it's being held in San Antonio, Texas at the University of Texas Health Science Center in Dr. Mark Feldman's lab. There's an introductory course for those that are new to this science, and that runs over April 8th and 9th. And then an advanced course, which is for those current users that want to improve their technique and look into more advanced survival models, cardiac disease, banding, things of this nature. So that is held on May 13th and 14th. If you're interested, please just go to insidescientific.com, look for the workshop link, and you can get all full details there and submit an application to attend if you'd like. All right, so yeah, with that said, I'd like to thank our presenters from Transonic today, Peter Plouf and Filip Konecny. There's a lot of thank yous coming from the audience, guys, so you did a great job. And again, thank you all to the audience as well. It's a pleasure to have you. Thanks for being a part of the Inside Scientific community. And yeah, have a great day, everybody. We'll see you again soon.